on nutrition. So we are going to really cover the gamut tonight. We have an incredible panel with us tonight. As you can see, our guests are coming from a lot of different angles throughout the medical facility, medical profession. And we're so thrilled and honored to have them here tonight, giving their time and the professional knowledge about what they see as patients and their experience with pertaining to nutrition specifically. They will each present some of their own perspectives here, and they will tell you how they want to go about with their questions and answers, whether it's at the end or in the middle. So I'm going to give it away to our tonight's host and facilitator, Margaret Bennett. She's also on the Seniors West of Teton's Board of Directors, and we're very, very happy to introduce you to her, and she will take away the rest of the evening. Will that take it away?
Hi everyone, thank you. Margaret Bennett, and I'm not used to using Dr. Robert Crouch is a doctor of osteopathic medicine and is a hospitalist at Teton Valley Health. Lisa Carlson, registered dietitian who has has transitioned into administrative roles at Teton Valley Health and is now our Chief Nursing Officer and Chief Operating Officer. And then Hillary Fournette is a registered nurse with St. John's Health. She's been a registered nurse for over 20 years and now currently works in utilization review. And when Hillary comes up, she can explain what utilization review is and how it pertains to nutrition. To give you a little rundown of the night, I'm going to start with a 10-minute introduction on physiological reserve. It's an important concept for nutrition, and I really want to make sure everyone has a good foundation of what this is. Then we'll move on to our panel discussion, and finally we'll have an open forum for questions. So let's jump in. So, physiological reserve. This is the ability of one's body to return to homeostasis after a stressor. So stressors can be expected, such as digestion of food, or breathing, or cell breakdown, cell regeneration. These are all normal things that our body is doing all of the time. Stressors can also be unexpected, such as getting the flu or being injured. We don't see that coming down the line. All of these stressors, whether they're expected or unexpected, all require energy to recover from. The important concept of physiological reserve is that it's our body's ability to return to homeostasis. The speed in which we're able to return to normal varies person to person and will decrease with age. Chronic illness is a major constant stressor for our body. So anyone here have a thyroid problem? I know I do. How about osteoporosis, or hypertension, or pain, or diabetes? All of these things are very common in our day-to-day. Since our bodies, mine included, are working harder at rest, we do not have the same physiological reserve to recover from a stressor as someone who does not have a chronic illness. And we see that every day. So again, who in here has thought, wow, this was a lot easier 10 years ago? Or man, this cold is taking so much longer for me to recover from. Before it only took 3 to 4 days. Now it's maybe taking 6 to 7. Hate to break it to you, but that's the same cold. It's not worse or different. It's not any different just because you're older. It just feels worse because you don't have the same physiological reserve to recover from that cold as you did before. So this is a tale of time. If we're lucky, we're born and we have optimal bodies. All of our organs are working well, everything is flowing free, our pipes are open, our heart is pumping strong, our liver and kidney are perfect. They haven't come in contact with any alcohol. You can run circles for hours, you can play all day, you're never tired. These kids, they break their arm, in 6 weeks they're healed. For us, we break our arm, in 6 weeks we're just getting out of sleep. So these kids, there's just a whole different ballgame for them, and it's because their bodies are working perfectly. Then as we age, we make poor life choices. And maybe we eat some really poor nutritional food as we get older. Now these kids, they have perfectly functioning GI tracts. They can eat pizza. They can drink soda all night. And they're not up all night with GERD or acid reflux. They don't need Tums to go to bed. They can lay down flat. While we're here, have 4 pillows keeping our head up because we can't lay down unless the acid reflux will come up. These kids, their GI tract is perfect. So they're able to digest these foods without any problem. For us, it takes more effort for our bodies to digest these types of foods so that we do not have the physiological reserve to handle a stressor that comes out of nowhere, like a flu or an injury. Continue aging, and we start partying, okay? Most Americans will add alcohol into their diet in their 20s, maybe around 3 to 4 drinks a week. Now, this is usually one of the first major consistent stressors that we're adding to our body on a regular basis. This is a conscious decision that we've made to add alcohol, poison, into our bodies for our bodies to filter. Oh no! What happened?
It's time to call.
Real. It's like, don't bash out here.
Don't bash out the low signal. Have to go out without it.
It's just the computer needs to wake up.
Yeah, this is. Okay.
It's just espresso.
This is a stressor. See? Exactly, Ken. That's exactly
See how
right.
fast Margaret
Okay, here we go. All right, we're back. Thank you. All right, so here we are. We're drinking. We're adding stressors to our organs. Moving on. We have a gentleman here. He has the cold. Maybe he has COVID. He's not feeling well. He does not have the energy to do much more than just lay around in bed all day. And you know, sometimes we need to get that.
Not an old person.
Not yet. All right. Now we also have emotional stressors. This is an important concept to understand. Another part of aging is receiving stressful news about our health. Maybe this woman just received a scary diagnosis. Maybe she's battling depression. Maybe she's going through IVF treatment and learned that it didn't work again. She's dealing with these stressors every day. All of these stressors, emotional and physical, drain on our physiological reserve and can drain us just as much physically as an injury can. Now, this is a little personal anecdote, but as a physical therapist, patients come to me to seek relief from pain. And often during an initial evaluation, as the history and the story starts to come out, it coincides with an emotional stress that's happened in their life. And sometimes it can be related to that injury. You know, stress of loss. They're not able to ski this season. There's grief in that. You know, we live here to play outside, and if you can't do it, there's loss there. But sometimes this emotional stress comes completely out of nowhere, and it's completely unrelated to their back or hip or whatever pain had brought them in that day. One man I was treating was really worried about a 4-day private school for his daughter. And another woman was really worried about a real estate sale that was going through. And now these are all things that are really relatable to us, I'm sure. I allowed my patients the space to talk, and throughout the whole 45 minutes, they pretty much just talked about their life and the stress they were going through. Well, a week later, they come back to work, and their pain is improved. That headache and that neck strain that woman was experiencing is eased because she was able to express her emotional stressor. The man, now his back pain is still there, but the tightness is eased, and he's now able to work through his And I use these examples to show how emotional stress can manifest into pain. And this pain and emotional fatigue will pull on your physiological reserve. So here we go. She's a little older, right, Nancy?
Sorry.
She's a little older?
Yeah, she's a
Okay.
little.
Okay. So, as we continue on our timeline, most people have a surgery in their life, okay? Whether it's elective or emergent, surgery is a major stressor to the body. It's an all-hands-on-deck situation to try to heal this new incision. Time of significant injury are times when we need to fuel our bodies with the most important nutrients to help with wound healing. Now let's think about this woman and let's assume maybe she has diabetes. Maybe she has numbness and tingling or neuropathy in her feet. She will have more difficult time balancing and trusting that knee when it comes time to walk. Maybe she'll have poor wound healing because diabetes affects our circulatory system. Maybe she has impaired eyesight because diabetes greatly affects the optic nerve and can cause blindness. So these are all things from one chronic disease that's very common that can affect this person's total knee replacement that has nothing to do with the surgery. But if her body is working hard to keep her diabetes under control, then she will not have the physiological reserve to recover from this surgery as well as maybe her peer does. So we've all heard, my neighbor had the same surgery and he was up in a week. Why am I still down? Why am I still using my walker? Well, maybe they have a different physiological reserve than you. Maybe they don't have the same chronic conditions as you. And maybe they're able to recover a bit quicker. Now I show you this timeline because it shows that the natural course of aging will stress our bodies. Nothing that I showed you here is beyond the pale of something that's normal for an American citizen, right? We all have been there. And it's important to realize that when we have chronic disease, our bodies combating it. And when we have a new stressor that comes into our life, it's going to have a harder time handling that new stressor. But it is not just doom and gloom. Okay? As we get older, yes, there's natural aging. There are things we cannot help. However, in the 6th and 7th decade of life, it is not too late to make changes in our physiological reserve. When we eat foods appropriate for our individual needs, we can improve our baseline health and therefore improve our physiological reserve and our scores. Food truly is fuel, and when we eat food that will make a difference, when you eat good food, it will make a difference in your body and how it functions. So we can improve our physiological reserve. We can help our bodies combat chronic disease, all with nutrition and exercise. And it's not too late to start implementing a good nutrition plan and exercise routine to help aging into your 70s, 80s, and 90s. So now I'm going to change this. Well, first, any real questions about physiological reserve? Kind of, we all get it. You know, the point of this, and I really want to spend a good 10 minutes here, because this is the why we need to eat well. We all are in this room because we've been told at least once you should be eating well. But what does that mean and why? And I really wanted to spend some time explaining why it's harder to recover from surgery. Why is it harder now to go for a hike and then the next day I need to take a nap? Why? And this is why. Yes.
Is frozen as good as fresh?
Is frozen as good as fresh? Well, I'm going to let our panelists answer that question. But in terms of this concept of physiological reserve, I'm going to end it here. It sounds like we're all on the same page. And our next panelist will be Dr. Crouch. And he's like you said, he's a doctor of osteopathic medicine and a hospitalist at Teton Valley Health. And he will be presenting on more nutrition and different. He will be presenting on aging and diet and how our diet may change as we age.
Yeah. If I just talk like this, can y'all hear me okay?
Yes.
Yes.
Okay.
Perfect.
Perfect. I'm just going to do that then, if that's okay. So I have a perspective, I came to the Teton Valley, grew up pretty close to here, but I came here from Boise where I worked at a family medicine residency, and I taught inpatient and outpatient medicine to graduates from medical school that are going through their residency program. So a lot of the questions that I've received over the years are from people that are training in medicine, learning how to talk to patients, and also from my own patients that I've taken care of, both in the clinic and in the hospital. My current job is very hospital focused, but I kind of pulled back from that other experience to add some things that I've been asked a lot. So feel free, I'm really used to getting questions as we go. If it's something that I'm going to cover later, I'll probably just redirect back to the slides, but I'm happy to have you interrupt me. One thing is I do tend to talk a little fast, and so if you need me to slow down or enunciate more, just raise your hand and get mad at me. It's okay, I'm used to it. So one thing that I like to start with is where are we right now with the recommendations from the governing bodies on what we should be eating? Because in your lifetime, it's changed at least 5 times, and I'm going to go through that here in a slide. So let's go to the next one. Did you know, so you can just click through this, and I'll just kind of talk about it. The very first recommendation we got was in 1894. Before that, there was no guidance at all on what things we should eat, what was healthy, what wasn't. In 1943, let's pause here for just a second.
What did they say in 1894?
Yeah, so it was the Farmer's Bulletin, and it was food for young children. All they said at that point was, you need to eat vegetables sometimes. It really wasn't that helpful. There wasn't a lot of guidance, really no evidence around it. How to select foods came out a little bit later. This was, wartime, World War II. A lot of this was actually geared towards how to eat and select foods that were on ration, because this was during World War II. And they also came out with the next thing, which is this food wheel. My favorite thing about all this, first of all, there's 7 chunks. One of them is butter. So if you were a child in 1943, butter was a food group. And, I don't see it up there, but yeah. So, not super helpful. I think the one that most people in this room are going to be familiar with is probably the next one, which are the 4 basic food groups. This one was running 1956 up until about the 70s. This is what a lot of people were learning. It was a little easier to understand, but there was no science to back it up. It actually was off of interested parties and farming organizations nationally that were lobbying in Washington to try and get their food up higher on the list. It really actually wasn't that evidence-based. So early 1990s, the food pyramid was introduced. I think the idea of the food pyramid was great, but again, a lot of outside interests went into this. And so not a lot of nutritional data, mostly based on who lobbied the hardest in the 90s. So there was a confusing thing that happened after this. You can go to the next one. I don't know what this is, and they tried to change it to my pyramid, and what it looks like is a big pile of food at the bottom of a pyramid that isn't very helpful to understand. So trying to clear all this up, where we are currently is the My Plate, and this is what the government is recommending for how we should pick our meals. There's also some problems with it. We'll talk about it very briefly. There's a lot of words on these slides, by the way. This is just a trigger for me to talk. We're not going to go through all these bullet points unless you have specific questions. It does encourage, it takes away some of the things like lots and lots of grains. If you look at some of those food pyramids, grain is at the bottom of the pyramid. Maybe it shouldn't be there. And so it kind of balances out the portions a little bit better. I'm not going to get too much into portions because Lisa's going to talk a lot about that and has some much better teaching tools than a slideshow, so I'm excited about that. But there's some problems with it too. If you go to the next slide, or the next one, you can just go to the next slide, just go through that. So there are some criticisms to this. One is, there's actually no evidence that we really need to be taking in a bunch of dairy. If you can get calcium and vitamins from other sources, you don't actually need dairy in your diet. One of the interest groups that did that was the dairy groups in the country really pushed to get that glass of milk on the plate. So the person that made this actually said some negative things about it, and we can just keep going. Harvard gave us a better one. Let's pause here. So this is taking the food, the My Plate, and giving actual evidence-based stuff. So I'm going to pause here and talk a little bit more about this. So very first is, you can see up in the top left corner, healthy oils. Oils aren't a bad thing. Fats are actually a good thing in our diet. We need them to build brains and have healthy bodies and healthy nerves and make sure that the system of the bodies are working appropriately and you're building up healthy muscle tissue. It's actually a good thing to have. A general rule is a healthy fat is liquid at room temperature. If it's solid at room temperature, like butter and Crisco, probably not great to include in your diet.
Now, I've heard something entirely different.
Okay.
That it's rancid if it's liquid at room temperature.
I haven't heard that.
Are you referring to butter specifically?
No, referring to like canola oil or all those types of oils.
Canola and vegetable oils are a little bit of a side group. You want to have more of a single origin oil, tends to be a little bit better, like avocado oil, olive oil, something that's a little bit less of just a hodgepodge of things. But as far as being rancid at room temperature, I know the oils can go rancid, so maybe throw them away if they're past their expiration date.
Or keep them in the fridge.
Or keep them in the fridge. That's a good idea. So more veggies and greater the variety, the better. Potatoes and French fries, remember, do not count as vegetables. That is a carb. It is not something that should be thought of as a vegetable. Did you have your hand up for a second? Did you raise your hand for a second? Okay, cool. Eat plenty of fruits of all colors. The idea of adding extra color to the diet is that is an easy way to add variety. Each fruit has its own set of minerals that you're getting, and so the more variety you get, the more variety of minerals you get. You're not drinking milk anymore, it's just a glass of water. We don't actually need to have a bunch of dairy in your diet as long as we're making sure we're getting those nutrients elsewhere. Whole grains, things like white bread, enriched rices, that kind of stuff, they don't have the same health benefit that the whole grains do. And so focusing, if you're gonna have grains, about a quarter of your plate, it's not gonna be, half of a food pyramid, it's gonna be a quarter of a plate and it's gonna be whole grains. And then protein. I have a lot more slides about protein later, so we'll get back to that. But some form of protein with every meal, and protein does not have to be meat.
Meat.
Now, what's that?
I thought you said protein does not have to be.
Meat.
And
It does not have to be meat. Yeah. All right.
I don't know what that.
That's okay. I have it on my phone just in case this happens again.
Oh, it does. Never mind.
All right.
I thought that was the end of it.
So that's a lot of information. It is really helpful, but you hear about all these other diets out there, and so I got a lot of questions about what is the most evidence-based of all the different diets out there. So I want to take some time to talk about 3 specifically. Mediterranean diet. I've never been there. I've never been there. It looks like a beautiful place. You just got back from Greece.
I wasn't in that exact one, but where I was, there was the white church with the blue top. It was really
So I hope for anyone that's traveled there, I hope it would bring them back to a happy moment. Absolutely. So the Mediterranean diet, I have a lot of slides in here about the research behind it, and if you want to get more into that, let me know. The basic points here are, actually, let's go to the next slide. This is really good, but we'll talk all about it later. There's some fish. Eat fish. Don't eat red meat. We'll talk about that too. So this guy right here, Mr. Ansel Keys, he is a physiologist. One of the first guys to study diet actually in the country. He and a group of other scientists were studying octogenarians. Have y'all heard that term before? Yeah. Okay, so octogenarian, somebody that's lived to 80 years old. Turns out that they kind of lived in these little pockets all over the country, all over the world, and there were a lot of pockets around the Mediterranean Sea. And so he was like, oh, that's kind of this weird collection of people. There's also one in Japan. There's randomly one in Iowa. I can't explain that one. But he, saw this collection or kind of clump of people around the Mediterranean. So we looked at what the diet was for the average person at that time. Remember, this was in the 50s. The average diet for people in the Mediterranean has kind of shifted more Western now, but regardless. So he looked at some outcomes here. So what he was initially studying was serum cholesterol and cardiovascular health. At that time, they didn't actually know that high cholesterol meant bad heart, so that was very new research at the time. They took some pockets of blue zones, we can go to the next slide, and looked at some health outcomes. There should be stuff on that one. Keep on clicking. That's great, let's just do it this way.
Okay.
Yeah, I'm happy with that. So, This is more of that kind of research-based stuff. I also give this lecture to med students and residents, so they like to hear the research. But if you want to as well, we can talk about controlled studies and looking at different groups with different diets and different interventions. But we can skip to the next slide, which actually has the picture I wanted to show you, which is these health outcomes down here. So the Mediterranean diet was used in the PREDIMED and the Lionheart study, and they showed in one of them a 16% improvement in all things like high cholesterol, diabetes, heart disease, and then in the other one there was a 76% improvement. So pretty massive improvement. If you've got things like high blood pressure, high cholesterol, cardiac disease, history of MI, the Mediterranean diet really has the best evidence to show that that's what you should be trying to do for your food. You can keep going. This one is actually about weight. So looking at some interventions on this study, you can see there is a low-fat diet, which is the red line. So that's just saying eat low-fat. There was an initial 5-pound loss, and then kind of this upswing, and then kind of a leveling out at around 3-ish pounds on average for weight loss. The yellow line is the Mediterranean diet. And you can see it has the same drop, but there's no increase again. You just kind of maintain that. And then there's this low carbohydrate diet, which is a very difficult diet to follow. You have a bigger weight loss, and then you rebound. And so looking at all of those, kind of that healthy weight loss and maintenance is seen in the Mediterranean diet. Yeah, there's a reduction in heart disease, cardiovascular disease, hypertension, hyperlipidemia, cancer, specifically colon cancers, type 2 diabetes, Alzheimer's disease, and Parkinson's disease all have positive outcomes if you follow this diet.
That means you get those things?
You don't. You have a less likelihood of getting those things. Yeah, thank you for clarifying. Yeah, that's an important difference. Here's another, actually, it's that very last point there. There was a study that showed preserved telomere length. Who here would know what that means? It's okay to say no. So telomeres right now are the things on the ends of your chromosomes that kind of help your cells divide, and they are heavily linked with aging. So as the telomeres shrink, that shows up as stress and aging in a cell. And so preserving telomere length is a great way to preserve cell health and actually improve life, essentially. So kind of cool. So somebody came and made a food pyramid for the Mediterranean diet. And actually, of all the things that I've shown you, I like this one the most. This is what I used to give my patients, because this one makes the most sense. It's the easiest to follow, and it includes some other things that are really important too. So at the very bottom of that pyramid is be physically active and enjoy meals with other people. That is really showing all the different categories of health. You know, social health is such a huge part of aging, and losing that social part of your world can be really life-limiting in a lot of ways. Physically active, very important. Drink water. You can have wine in moderation. The biggest chunk of foods that you want to eat, they actually lumped grains in with fruits and vegetables, because a healthy grain is just as healthy as a good vegetable. And the protein sources of beans, nuts, legumes, the non-meat protein sources are really, really healthy for your body. Up next from that, a couple times a week, you can have fish and seafood. There's a lot of really healthy oils in there. It's a really healthy source of protein. I think you've got some portion sizes back there for fish. It's a pretty good thing to do. You don't have to do it more than a few times a week. Above that, you've got poultry, eggs, cheese, and yogurt. That's moderate portions, maybe once a week. You really don't need to do it more than that. And then up top, you can see candy and steak. Basically, according to this, red meat is candy. It should be thought of in a very similar way as candy. It's not something you should think of for health. It's not going to kill you if you have it every once in a while. Life is about the sweets too, and you can absolutely do that, but just do it in moderation. Really focus that diet in those other areas. So this is my favorite one. That's what I used to hand out to people. There's some links there. Does anybody want to talk about the vegetarian diet? We can also just kind of skip this. We're kind of running a little long. Vegetarian diet, anyone interest in that? Basically, you can be healthy with the vegetarian diet. Oreos are also vegetarian, and so there are bad ways to be a vegetarian too. So just really, if you do a vegetarian diet or you want to look into it, make sure you're doing a healthful vegetarian diet and not just thinking that it's healthy because it's vegetarian. That's kind of the point of those slides. So this is kind of the slides that I added for this group. So really focusing in on us here. I think, oh yes.
When you do talk about vegetarian diet, what are the proteins that you're
Yeah, great question. I think I actually have a slide in here about the proteins for different things. Only a couple of them are meat and a lot of them are legumes, beans, that kind of stuff. But yeah, that's a great question. So I think Margaret did a really good job talking about physiologic reserve. This is something that comes up in my job currently a lot because we do inpatient medicine and we also do this thing called swing bed, where if you need a little extra time to do some rehab after a hospital stay, or you've broken a leg and you just need some extra help before you go home, we take care of you in the hospital. And so many times nutrition comes up and physiologic reserve comes up as a factor in how long that swing bed takes. You know, if you're somebody that's pretty healthy and can bounce back, you got a couple of days with us. We've had people there for months before because it's just taken a really long time to ramp them back up to healthy. So that's something we see a lot. Yeah, there's this thing called the frailty index. If you were, you know, I don't know, in healthcare for a while, that might be really interesting to you, but we like to put people in categories and give people scores and put things into numbers, and this is just one of those scoring systems that we use. So we can keep going. Malnutrition is an important word to talk about. When y'all hear the word malnutrition, what does that mean to you? Somebody's malnourished.
McDonald's.
What's that?
McDonald's.
McDonald's. We'll come back to that. That's perfect. Yeah.
The children in Gaza.
Mm-hmm. I think that's what usually comes to mind is like starvation, people that don't get enough food, war-torn countries, places that it's you know, there's a lot going on outside of diet, but actually we see it a lot in our elderly population. Malnutrition is either under or over nutrition in certain categories, and we don't just look at it as someone is malnourished. You can have plenty of protein and be completely deficient in vitamin D or something. You can have lots and lots of calories coming in, and in fact, you're wasting away because you're not getting enough protein. And so we as physicians like to look at the different macronutrients and micronutrients and make sure that people are getting enough of each of these categories. Down at the bottom, you can see 10% of people living in their own homes did not eat enough food, so are not getting enough calories. And 1/3 of people over the age of 65 eat too much, so that leaves only about 50%, 60% of people that are getting the right amount of nutrients in. So it's really prevalent. Protein malnutrition, I think, that's what I wanted to harp on the most, actually, because the protein malnutrition factors into almost every single one of our hospitalized patient visits, I feel. It's not getting enough of the recommended levels. We look at this with muscle loss and atrophy. We have a lab that we look at called albumin. If you ever go to the doctor and get your lab panels, that's actually always on there. We may not always talk about it, but it's listed there. So if you ever want to look at your labs and say, hey, am I getting enough protein? This is a way to start. It's not the only metric, but it's an easy one to take. Yeah.
What would you suggest for lab tests to find that out?
Malnutrition lab tests. So that's a great question. Can we get 2 more slides ahead and then I'll come back to that? I won't forget. Okay. So calorie amounts doesn't change that much over time, but it actually does decrease a little bit. Over the age of 60, you go down by about 500 calories a day-ish. I'm sure you've got more insight than that, but for a man in their 30s, it's about 2,500 calories a day. Over 60, it's about 2,000. And then when we get down to about 1,600. Don't count calories though. So counting calories has been shown time and time again to waste a lot of time, increase a lot of stress around what you're eating, and not actually improve any outcomes. So counting calories, I really, really discourage people from doing. If you're bored and want to do it and you need a hobby, go for it. But you're probably thinking too much about what you eat, and really the important thing is if you eat a lot of healthy foods and you're eating out of the right categories, you don't really need to worry about calories too much. So, we can go to the next one. Micronutrient malnutrition is another thing that we see a lot. We treat it a lot in the hospital. it's not something that I recommend you focus too much on. Really just try and broaden out that diet. Get a lot of vegetables that are different colors. Take a multivitamin if you'd like. We test for them all the time, but there's no good symptom from a lot of these. No reliable set of symptoms. If you've got certain diseases like high blood pressure or something, your physician should be following a lot of these electrolytes and micronutrients. It's not something that I'd recommend you lose a lot of sleep over, but you may end up, if you're, say, taking Lasix or something like that, you maybe put on a supplement sometimes. It's just work with your physician on that one. If you have questions about it, then it's really going to be based on what diagnoses you have. And so that's why I wanted to pause a little bit on that question. There's no good nutrition panel because every single person is different. Everybody's diet is different. We always check what's called the CMP, which looks for kidney and liver function, checks for a couple of electrolytes as well, so salts and things. But then after that, it depends on what your bone density is. It depends on how much sunlight you get. Is it wintertime or summertime? Is it, are you taking spironolactone? Are you taking, losartan? Like, it really just depends on what you're on, and you should really tailor that to each individual person. So, anyway, let's go to the next one. There's some things that can affect micronutrients, but I really wanted to get into this because this covers, I think, another question that I have, which is how do we get protein if it's not in meat? So you can see on the right, and I think you actually have a similar slide to this. Beef is the greatest source of protein at once, but it also has all the cholesterol and salt and things with it. So yeah, it's a big chunk of protein and a lot of other stuff. Meat are the top, or like in the top 4. Greek yogurt's actually way up there, so it's a great source of protein. And then after that, you can see lentils, almonds, milk, quinoa, chickpeas, egg. Some people consider that as an animal product. Some people are a little more lenient. Oatmeal, spinach, green peas, and the general idea is each of those have a certain amount of grams of protein per serving. And a good example of, or a good easy way to calculate how much protein you need in a day is take your weight and divide it by 2. That's how many grams you should be aiming for. And then you can find tables like this all over the place to then add up all the different sources of protein throughout a day. So average person's around 150 pounds, that's 75 grams of protein. If you eat, a couple servings of lentils in a day, you'll get there. If you mix that with some egg and a little bit of salmon for dinner, a cup of Greek yogurt in the afternoon, it's pretty easy to add that stuff up. How am I on time? I can be done anytime. That was the slide I really wanted to
I
get
think
to.
we still have time.
Okay.
But yeah, let's do a couple.
Okay, that sounds great.
Go like 5 minutes.
All right, sounds good. Other things that we want to include are fiber. I think that one gets forgotten a lot. Low fiber is a really big problem because it causes constipation. Your doctor's going to talk to you a lot about constipation, and it seems like a really invasive and silly thing to talk about, but we know that constipation is linked to bad health outcomes. It's also linked to prolonged hospital stays and worse mortality in the hospital. So eating a lot of fiber is actually important, and having a good bowel movement is important. Yes?
What would you consider constipation?
Yeah, great question. So there's the way that a lot of people think about constipation, which is how many days am I going between bowel movements? The way that we as physicians think about it is when you are going to the bathroom, A, is it easy or are you straining? And B, are you stooling enough to clear what's in there? And so even if you're going to the bathroom every day, but it's pebbles and firm and you're getting all backed up in your system, you're actually still constipated, even if you're having a bowel movement every single day. So fiber supplements are awesome. Foods that are high in, go ahead.
What's fiber? What's the source?
Yeah, great question. So basically, vegetables that you have to chew a lot generally are a good source of fiber. Cabbage is a great source of fiber. Leafy greens are a really good source of fiber. A lot of us just need to take a fiber supplement. The best one out there right now is Miralax. If you stir that into a cup and drink it, that's going to be your best bet. There's a lot of other natural sources of fiber. In my opinion, they should just throw it in the drinking water because it's such a common problem. But there's ethical issues with that, and I understand. So, yeah, so 30 grams per day for men, about 21 grams for women is the current recommendation as a starting point. If you're still constipated with that, go up. Healthy fats, we talked a lot about that. Yeah, butter and shortening, sorry about that. I know they're tasty, but they're not healthy. You can have them sometimes, just not all the time. Fruits and vegetables, non-fat, low-fat dairy products. One thing I did want to bring up is dairy alternatives need to be fortified with calcium to really count as like a dairy substitute. A lot of the reason why we recommend dairy is because of the calcium content, and so just make sure that you're getting, if you're on like a soy diet or something, just get it with calcium. Do you have anything to add to that? Okay, that's good. Cool.
Well, let's end it there and then we'll go to Lisa.
Yeah,
That
perfect.
sound okay?
Yeah.
Great. Thank you. Lisa, would you like to toggle or do you want me to toggle?
I'll stand here if you don't mind, yeah.
Great.
I'll stand if that's okay, so that way I don't have to like complain that quite so much.
Lisa, would you like a microphone or are you good?
Can you hear me okay?
Yes.
Okay, if you can't, let me know. So just while Margaret is queuing up the slides, my name is Lisa Carlson. I'm a registered dietitian and a registered nurse, and I do currently work at Teton Valley Healthcare. So we'll get going. Kind of a little bit of background. I started off as a registered dietitian and did that for about 12 years or so, and then in my 30s kind of wanted a little bit more hands-on with patient care and decided to go to nursing school, and throughout the course of my career kind of wound up in Driggs, Idaho here as the chief nursing officer. So it's been a lot of fun chapters and a lot of journey along the way. I'm going to be a little bit more specific on Dr. Crouch did an amazing job talking about the overview of diet and which diets are healthy and kind of the theory. And I'm going to get a little bit more specific, talking specifically about water and protein and serving size, and like interactiveness, like questions, so please feel free to ask questions along the way. Water, super important, very, very easy to ignore, right? Very, very easy to avoid, because the more water we drink, guess what? The more often you're going to the bathroom. The more water you drink, the more often you're going to the bathroom in the middle of the night. So you kind of learn over time, like, I'm not going to drink so much water. However, water is super important, especially if you do suffer from things like constipation, dry eye, any kind of signs and symptoms, dry skin. It probably means you're not getting enough water. I do have a few math calculations in here, so don't worry about math. If you need help in any area after the lecture, I'm very happy to work through some math questions for you if you have specific questions about needs. But basically for the older adult, and I'm classifying and defining the older adult as 65 years or older, they should be drinking 1.5 to 2 liters a day. And a liter, if you use the visual of those big soda bottles that are about this big and this big around, that's what a liter. So 1.5 to 2 of those a day are what the average older adult should be drinking. That's a lot of fluid. Did you have a
No, I was gonna say that's a liter right there.
Yep, that's
The blue? The blue.
the blue, probably the blue one right there. Yep. But don't get overwhelmed by it. There's lots of ways you can get fluid into your diet. It doesn't just have to be drinking it all day long. But the most important thing, adequate water intake helps with food digestion, nutrient absorption, and it helps get rid of waste. So, and I really can't stress that enough. Constipation is a huge problem as we age. It affects everybody. We always kind of joke that, as you age, all of a sudden you start talking about how many prunes does everyone eat a day. It's a real thing, right? Your GI system, the peristaltic activity just slows down as you age. So adequate fiber in your diet, I can't stress enough. Adequate water in your diet, I can't stress enough. Okay, signs of dehydration in the older adult can lead to a variety of things. We here in Driggs and Teton, Victor, we live at elevation, right? We have distinct hot summers. We have a lot of incidental losses that we might not even be aware of, like sweating, and sometimes you perspire and you don't even really recognize you're sweating. But it can lead to very serious outcomes in the older adult. Increased confusion, tiredness, lightheadedness. A good indicator is your urine. Yeah, in medicine, we like you to look at your urine, we like you to look at your bowel movements, we're a little bit weird, we do ask about it. But when you go to the bathroom, what does the end product look like? Is it clear? If it's clear, you're probably getting enough fluid, you're probably okay. If it's yellow, you can probably have a little bit more fluid in your diet. If it's dark amber, dark yellow, that's a sign of dehydration. That's a cue to yourself that you're probably not getting enough fluid in your diet. Foul smelling urine, urinating fewer than 4 times a day. If you're like, gosh, I haven't gone to the bathroom in a long time, and I always try to tell people, you know, you should really be going to the restroom and urinating about every 2 to 3 hours. That's a good indicator that you're not getting enough fluid, especially if you're exercising. Very easy to lose track of your hydration status when you're exercising. If you're out and hiking, boy, and you're not pulling over to the local bush every 2 to 3 hours, you need to start thinking, I'm falling behind on my fluids. I need to start having a little bit more fluids in my diet as I'm not exercising.
Could I mention?
Yes.
We, as a health talk, we had someone here explaining our pelvic floor.
Uh-huh.
And she suggested to us that we should try to hold it so that we don't go more often than 5 hours at a time.
Well, that's a whole different subject of pelvic floor
Right,
exercising.
Yeah, I mean, it's a totally different message.
Well, yes and no. I'm talking about hydration. If you have frequent urination due to weak pelvic floor, there might be reasons why she's recommending like Kegel exercises or pelvic floor exercises and not wanting you to urine as much, so you maintain the muscular structure in your pelvic floor.
I think that was her message.
Yeah,
for sure.
yeah. So I'm talking right now just about hydration and what are the indicators that you should look for.
And when you feel like you need to go to the restroom.
Yes, so for the normal elderly adult,
2
2 to 3 hours, if you're hydrated, you should be using the restroom.
Okay.
Yeah. Dry mouth, lips, eyes or skin, lower blood pressure, and disorientation. So all signs of potential dehydration in the older adult. Chronic dehydration, if you're somebody that just doesn't drink a lot, can have prolonged effects on your system over a lifetime, especially as you go into your 80s or 70s and 80s. Problems with memory, poor concentration, slow reaction times, feeling of being like just extra tired, run down, fatigued, weakness, can lead to more falls, pressure ulcers, skin conditions, urinary tract infections, something we see a lot in the hospital, kidney problems and constipation. And I have urinary tract and constipation underlined because those are 2 major conditions in the older adult that are very common that we do see all the time in the hospital.
Lisa,
Yes.
the pressure sores,
Mm-hmm.
what does that affect? What's affecting that? What's causing it?
So a pressure sore is if you lay, like if you're not feeling like full of energy or you're feeling like a little bit lackluster and you're like laying in one spot for too long, you will actually get a pressure, like the increased pressure and not moving will decrease the blood flow and can cause, it could lead to pretty significant sores.
Okay.
And those sores have a huge variety of impact on one's life, depending on if they're just superficial, if they end up going through the muscle, if they can go actually into the bone.
Okay.
They can be actually almost life-threatening for some people.
Okay.
Yeah.
Thank you.
Anything else you want to add on that?
Just that dehydration is a factor, because if there's not enough blood volume, then you're going to have easier time getting pressure. Same thing with low protein can be associated. A few other vitamins like vitamin E are also associated with increased risk of bed sores. So nutrition is a huge part of that.
Yep. Perfect. Thank you. Yeah. Simple tips to get enough water. Sip on drinks throughout the day. Have a full glass of water if you take any medication or vitamin. Don't just take a sip to get the pill down. Just take the time to drink the whole glass of water at that time. Freshen up your water. There's lots, you could put like a lemon, a lime. There's lots of little additives, kind of like flavor sources at the store. I think one is called like Mio. I see like the young teenagers kind of drop in like Mio drops into their water nowadays. Take sips. Take the time when you're eating a large large meal for portion control to, take a couple bites of food and then drink, a glass of water, a couple bites of food and a glass of water. It's a good way to get extra water in. Eat soft foods, wet foods that have high water content. That would be more indicative of your fruits and vegetables. Jello has a higher water content, things like that. You can set, a daily tea appointment with a friend. Again, the social aspect of eating is super important. Don't just sit there and eat alone, but incorporate, not just eating food, but also drinking and interacting at the same time. And limit alcohol and caffeine. Those tend to dehydrate you and not hydrate you.
Question,
Yes.
does seltzer count as water? And how much seltzer would you like? Would you have to drink more seltzer to come up with the 2 liters a day?
So that's a really good question. And I remember when Dr. Feisel was here speaking on it, that same question got asked. And her answer, and so I will follow what she said, is that she recommended drinking more seltzer than just, so if you wanted to drink all seltzer, I would probably err on the side of 2 liters of seltzer versus the 1.5. So, and then following her recommendations.
What would that mean?
Well, according to Dr. Feisel, it had to do with the carbonation that was in the seltzer, so you had a little bit more air. You weren't drinking just pure water. Yeah. So. Yeah. Questions about hydration and fluid? Okay, we're going to move on to, yes?
What do you think about, people that are concerned, you brought this up about having to urinate a lot at night and kind of front-loading their water intake so that towards the end of the day, they're not drinking as much so they're not having to go to the bathroom?
So I personally would encourage that.
Yeah.
I personally am one of those people that really try to limit my liquid intake after 3 p.m. because I am one of those people that will be up like what seems like every 15 minutes all night long. So I'll drink, most of my liquids in the morning. And really, when I hit that 3 o'clock in the afternoon, I start curtailing how much liquid I have. And that's just for me personally. But I think getting the liquid in is significantly more important than not getting the liquid in.
Okay, thank you.
Yeah, Dr. Crouch, do you agree with that?
Yeah, and also watch your medications too, because some of them can also make you pee at night. And so if you find that that's an issue, review your meds with your primary care doc and make sure the ones that make you pee are in the morning.
In the morning, yep.
That's a good note.
Okay. We'll move on to protein. Protein, super important. Dr. Crouch mentioned why it was so important in the elderly person, older adults, again defined as 65 years or older. It is recommended that the average older person of good health, not having any chronic illnesses that would restrict protein like kidney disease or other things like that, should probably have 1 to 1.2 grams of protein per kilo of body weight per day. So and this is where I was saying, don't do a little bit of math, but don't worry about it. If you have questions, I'm happy to answer. So 1 kilo equals 2.2 pounds. So just like Dr. Crouch said, very, very easy reference. Take your weight, divide it by 2, 150-pound adult, roughly 68, 70 grams of protein per day. Perfect. So protein needs, ideally, 68 to 82. If you round it to the divided by the 2, you're in the 70. You're in the ballpark. I don't think you're going to go wrong with that.
Would
Yes,
you
sir.
agree you can't have too much protein?
No, you can have too much protein. Yeah, you can have too much protein, and actually, if you do have too much protein, it is hard on your internal organs like your kidneys to kind of digest it. So you really do want to follow what's recommended, and you do really want to follow what is the advice of your provider based on your past medical history and what's going on with you on a physiological level. Yeah.
It is hard to get to those levels, but yeah, we have seen kidney failure from too much protein supplementation.
Mm-hmm. And I think a classic kind of stereotypical athlete would be like your bodybuilder,
Right.
that really protein loads all day long, protein supplements. We have seen some bad outcome in those types of patients and those athletes.
But is it okay for those type of athletes to eat more protein than you're recommending here?
It is, and they would have an adjustment based on their athletic need. And I would highly encourage those type of athletes to talk to a registered dietitian, or their provider, so it was their protein needs were calculated based on their height and their weight and the amount of activity that they were doing.
Thank you.
You talked about food sources for protein, but now you see a lot of protein shakes and protein powders that you can add, or is that, you don't think you're getting enough, is that a good route to go?
I don't personally have any problem with that. I think if you have limited appetite for various reasons, or you just know for a fact you're not getting in enough protein, you've calculated it, you know, a protein shake to help supplement your protein, you know, there's Ensure that's out there, there's lots of different products out there. I don't think there's anything wrong with that.
I read an article the other day about how important it was to spread the protein out during the day rather than lump it all in dinner, you know, where we're used to having the big piece of meat. And it said that, you know, a lot of breakfast foods, even that are high fiber and, you know, touted as being very good, like oatmeal, have some protein, but not really. You shouldn't aim for more at breakfast and lunch.
Yep, I would agree with that. I think, you know, smaller frequent meals are easier to digest. You're not getting quite the load. You're not causing quite an organ stress at one time. It really kind of is recommended to eat your bigger meals earlier in the day and smaller meals at night. So I think probably the article you read probably had sounds like it was kind of right on the same topic. Yeah. Did I answer your question? Okay, super. Yes, ma'am.
I missed the moment. I'm going back to dehydration. What are your thoughts about Pedialyte for elders?
I think if you're not able to get in adequate liquid in other sources and you feel like you're dehydrated and you have signs, and you've talked about this with your physician or a registered dietitian, especially if you're under a stress situation, I think Pedialyte is fine. You know,
It said that his juice a little bit,
I
but it's an extra boost.
I think it's fine, and it's a way to get a little bit of extra, you know, spark in his diet, or whoever you're referring to. It's not going to cause him any harm.
Thanks.
Yeah. And sometimes, like when people don't feel good, like if they have the flu bug or, you know, cold or something, their eating and their drinking kind of falls off. And sometimes like a frozen Pedialyte popsicle or something like that is just an easy way to get a little extra boost and a little extra hydration at the same time with something that's soothing for you. So there's all kinds of tricks of the trade.
Really
That's
quick.
correct.
I'll be very fast. I agree with everything you just said, and also those like liquid IVs and Pedialyte and Gatorade, very, very high in salt. And so if you have a condition where you need to avoid salt intake, be very careful with
Yeah,
those.
good point. Thank you. Yes, ma'am.
What's the opinion on Gatorade, Powerade?
Yeah, I think that was what Dr. Crouch was just referring to. So any of those supplements, they do have a lot of sodium and potassium. And so sometimes certain medications want you to limit your potassium as well. So I would run that by a registered dietitian or your provider, just to say like, hey, is it okay if I drink one Gatorade a day or half a one, or what would you recommend based on, you know, my physiological, you know, diagnoses, past medical history, and the medications that I'm on, and the multivitamins that you're taking too.
Sometimes it's the lesser of two evils.
Sometimes,
Right.
yeah, sometimes it is. And that's why you should really make sure what you're doing, you're running it by your primary care doctor. Importance of adequate daily protein intake. Why should we take protein? It builds muscle. It increases fat burning. It decreases the risk of age-related muscle decline. It improves the healing of cuts and wounds, helps with blood sugar stability. It's essential for proper brain function, increases energy level, increases bone health, and it improves overall vitality. So protein is something that is very important, whether it's animal-based or plant-based. Every person needs an adequate amount of protein in their diet, and that's super important. Health risks of inadequate protein, muscle loss, and that's very common that you see as you start to age, especially in your 70s and 80s and into your 90s. Weakened immunity, you become more susceptible to the common cold and flu, just germs out there. Slower wound healing, we see this all the time, and Dr. Crouch was referring to that. This kind of what, you know, the albumin indicator that we check people's labs. We're checking that indicator to say, what is their wound healing going to be like, or what is their susceptibility to fight off the current disease that they're being hospitalized for. Decreased energy, decreased bone health, and you see that with like osteoporosis. It's very common that you hear like an old person falls, or they might have fallen in Margaret's lecture when you're 8 and you can fall and not break an arm, and then when you fall in your 70s, all of a sudden you got a broken wrist or something like that. And then increased overall health fragility, definitely. Signs and symptoms of inadequate protein intake: muscle loss, weakness, fatigue. You can also see it related to your skin, hair, and nail problems, slow wound healing, increased risk of infection, edema, changes in appetite, increased bone fractures, fatty liver, and increased feeling of hunger. Protein often, if you have an adequate protein diet, you have increased satiety, so you're not as hungry as often. People that tend to have a diet based more on carbohydrates will have really high sugar rushes, and then their body will like produce all this insulin to kind of combat the breakdown of the carbohydrate, and then they kind of crash down, and then the body's like, I'm hungry again, feed me. And so then they have more carbohydrate, and they kind of go on this roller coaster ride of this blood sugar instability, where when you do have adequate amount of protein spaced throughout your day, your blood sugar tends to be a little bit more stable, and you have increased satiety, therefore you have better portion control and things like that. You don't tend to like gorge as much as you would if you're feeling like you're starving. Best animal-based protein sources. I think this is kind of answers one question that got asked earlier today. Lean meats, not fatty meats. Lean meats. You don't need all that extra fat, that saturated fat. So chicken, turkey, pork, lean pork. If you are going to cook some beef, cut off the fat before you cook it. So all that the meat, the protein part of it, isn't being, you know, re-soaked up and saturated.
But wait a minute, that's where the taste is.
Well, Dr. Crouch did say once in a while was fine.
It's candy. You can have it sometimes.
Yeah, once in a while is fine. Fish and seafood, you know, salmon, tuna, other fatty fish are excellent sources. They're rich in omega-3s, fatty acid, which support, you know, great overall heart health and brain function. Dairy products, eggs, cheese, Greek yogurt, excellent sources of protein, and eggs. I really can't say enough about eggs. So the white part of the egg is the albumin, and everything in a protein measurement is actually related to the white part of the egg. It's related to the albumin. The albumin, the white of the egg, is really considered, if you're scoring it, it's considered the 100. Everything else, all the rest, the meats, the beef, they score somewhere around 75 to 85 if we're scoring them. So the white part of the egg, which is the albumin, is really, it's highly digestible, it's highly utilized by the body. It's actually highly recommended if you are trying to increase. Not so much the yellow part of the egg, not the yolk, the yummy part, but the white part.
So how many eggs is okay for a day? Good ratio?
For a day,
Yeah.
so 7 days a week,
Oh,
4 days a week. I think you have to balance out your whole diet, and I think probably if you're eating eggs 4 days a week, like one egg 4 days a week, you're probably just fine. But you know, you have to take into factors genetically. Are you running a high cholesterol level? Are there other factors that, do we want you to just eat the white part of the egg and maybe not so much of the yellow part of the egg? So, well, that kind of leads to a different conversation.
Boiled or the scrambled.
Yeah, are you saturating them in butter? Are you mixing them with bacon? Yeah.
Yes.
Yeah. Are you cooking them in bacon fat? I have a lot of people I know that cook their eggs in bacon fat. Yeah. Best plant-based protein sources: beans and legumes. You know, lentils, chickpeas, black beans, kidney beans, all excellent sources of protein. Nuts and seeds: almonds, walnuts, chia seeds, flaxseed, great sources. Soy-based products are great, and then just basically, you know, whole grains, oatmeal, brown rice, and things like that. Okay, any questions about protein before we move on?
Is there any difference between an organic soy product versus non-organic on the soy level of protein? I mean, would you have any concern as a registered dietitian?
No,
Okay,
no.
okay,
One is gonna be more expensive than the other.
okay.
Yeah.
I was gonna just mention, I've seen a lot, feels like lately, just like lots of, pastas that have high protein, or, there's a lot of products now where they're adding in protein. What do you think about that?
I don't have a concern about that. I really don't, especially if you're someone that's trying to get a little bit more protein in your diet.
Yeah.
I think it's fine. Serving size. So this is the best part of the whole lecture. Everybody is always concerned about, I have to go on a diet, or I'm trying to do better, so now I have to measure, I have to weigh, I have to get things special, it's so much extra energy. It's not. Everybody has a hand, right? All you need is your hand. For adequate portion size, all you need is your hand. So for protein, if you're wondering what's a good size of protein, what should I be eating for my protein? The palm of your hand. That's roughly the diameter of your hand and the thickness, give or take a little bit, doesn't have to be exact, about 3 ounces of protein, which is 21 grams of protein. So
Sounds like a hamburger.
that's a hamburger. Yep. That's a hamburger. Yep. So protein sources: fish, chicken, pork, beef. Just the palm of your hand is what you should be eating, and that's considered an adequate portion size. Veggies. Make a fist. Veggies, about the size of the fist is what should be on your plate. So if you have a fist size of veggies, you got a good portion of veggies. If you want 2 portions, have 2 fistfuls. And I think that goes to my plate. It should probably be 2 fistfuls if you're increasing your vegetable intake.
Potatoes don't count.
What?
Potatoes don't count.
Potatoes don't count. Potatoes are half. Fat, not the whole thumb. The knuckle. Wiggle your thumb. It's the knuckle. It's from this part up. Is a easy serving of fat, whether it's kind of liquid or cubed butter. And then carbohydrates. So that would be rice, pasta, your potato. If you cup your hand gently, what can easily fit in the cup of your hand? So you don't need to measure. You don't need to weigh. If you go out to a restaurant that gives you a huge steak this big, use your hand, cut off your portion. Put the rest to go home. You got dinner or lunch for the next day or 2. Super easy. You always have your hands. Easily broken down into protein, vegetables, fats, and carbs. On the back table back there, I do have a lot of little food samples for some protein sources, some carbohydrate, vegetables, fruits, and some desserts. You kind of can get a little visual on what would be an adequate portion size. Portions are easy as Americans to eat too much of because you go out to restaurants and they really, as Americans, we kind of view value for volume. The bigger the meal you get, the more you feel like, wow, this was a great restaurant. I got a lot of food. And because I paid for it, I'm going to eat all of it. And then guess what? I got to open my belt 3 notches. And then you're up all night with GERD because you feel sick, right? So the food's not going anywhere. Take your portion, eat what makes you feel comfortable, take the rest home and have it the next day. Then you feel great. You sleep good, feel good. But yeah, just kind of ending it with any questions about protein, water, portion size. Thank you for allowing me to speak. I really appreciate it.
Thank you.
So now Hillary will just a little bit, Hillary doesn't have the nutritional aspect to kind of add to the discussion, but from a hospital standpoint and admissions, and she's going to speak to malnutrition and then the importance of utilizing resources when you are discharged. So from the hospital. So Hillary's going to take it from here.
Thank you. Margaret and Lisa and Dr. Couch have all said so many important and wonderful things, and so I'm not sure how much I can add, but I'll tell you a little bit about what I do. I'm a registered nurse at St. John's Medical Center in Jackson, and I am a utilization review nurse, so nobody really knows what that is. And what I do is I look at every patient that's admitted to the hospital, and I look at their medical necessity and essentially make sure that the hospital gets paid for their stay. So I communicate with their insurance companies, I make sure that we're following Medicare rules to make sure that we're reimbursed for the patient's stay. In doing that, I'm looking at the patient's course in the hospital. So I'm looking at how their illness or their injury kind of progresses and as they get ready for discharge. So, I just kind of thought a little bit about specifically hospitalized patients and some of the things that we might see when a patient is malnourished in the hospital and how that affects their hospitalization. We know that the longer a patient is hospitalized, the worse outcomes. There's a higher infection risk. It's worse for their mental and emotional health. It reduces their functionality. Oftentimes patients that are in the hospital longer have to start doing physical therapy. They're just end up going home weaker and with kind of more vulnerability and definitely at a higher risk for readmitting to the hospital within 30 to 60 days. So, we've talked a little bit about, or a lot about malnutrition and how malnutrition can be undernutrition, but it can also be overnutrition. And so, malnutrition we know can come for lots of different reasons. We haven't really talked about this too much, so I just wanted to mention that as you're thinking about yourself or your loved ones, and who is at risk for malnutrition, things like mobility impairment. So if somebody has arthritis or other reasons for an immobility, it's harder to prepare meals. It's harder to shop for meals. So that's just something to be aware of. I think we mentioned that, Margaret talked about the time progression of folks and how different parts of our bodies don't work as well, and certainly the gastrointestinal tract does start to slow down as we age, and so that affects how our nutrients are absorbed, and we're not able to absorb nutrients as well. Tooth loss is also something, if we don't have all of our teeth, then it's going to be harder to chew certain foods and to do that initial step of digestion. Impaired swallowing function can certainly increase malnutrition. Loss of appetite. Loss of appetite can be for many reasons. It can be due to medications. It can be due to a chronic illness. It could also be due to maybe an emotional stressor or depression. As we age, we might have a decreased sense of taste or smell, and that can also affect the foods we choose and how we enjoy them. Functional dependency, again, if we are, reliant on, a wheelchair, walker, cane, that sort of thing, harder to get around and prepare or purchase meals. Cognitive impairment can also affect our nutritional status. Polypharmacy, that's the number of medications that one person is on. If they are on multiple medications, that can affect nutrient absorption and interaction of different nutrients. And then one thing I want to also mention is inadequate socioeconomic conditions. So somebody who's on a fixed income, might have to decide whether to choose to pay for their medications that month or whether they can afford, more of the healthier choices for food. So something else to be aware of. And around 7% of seniors are reportedly food insecure. So it's not a small amount, and that's another reason why our senior center is so wonderful, providing amazing food for our lunches here, but also for home delivered meals. Loneliness, need for feeding assistance, so someone who, again, isn't able to feed themselves. And then conditions like dementia, delirium, and Parkinson's are also big risk factors for malnutrition. So just some statistics and some different kind of key takeaways from some studies that I looked at. Hospital malnutrition is estimated to affect 50% of hospitalized patients. And then a lot of patients can develop malnutrition while they're in the hospital. it's often unrecognized and underdiagnosed. It's estimated that only about 7% of patients in the hospital are diagnosed with malnutrition. We do see a threefold increase in hospital costs when a patient is malnourished, and so, you know, from kind of the hospital administration standpoint or the revenue integrity standpoint of a hospital, you know, it is important to identify these patients and make sure that they're getting the care that they need. And a really important thing is that patients are going to have a longer stay and be at a higher risk for dying before they discharge when they are malnourished. Another interesting statistic is that about half of patients who fall while they are in the hospital are malnourished.
Half?
Half, yeah.
Wow.
And of course, you know, patients that are malnourished tend to, as we've talked about, be more frail, have weaker bones, and so the falls often are more catastrophic. So talking a little bit about readmission. So we do look at, you know, patients and their readmission risk, and then look at those patients when they come back into the hospital, trying to, you know, mitigate those factors. So 23% of patients with malnutrition are readmitted within 30 days. So it's a pretty, it's about a 50% increase over patients that don't have malnutrition. And those patients that are readmitted that are malnourished, they are twice as likely to be diagnosed with sepsis. So I think we talked a little bit about infection risk with malnutrition, but malnutrition greatly affects your immune system. It affects the parts of, you know, the immune system that fight off viruses and bacteria and also create antibodies. And so when we're malnourished, our immune system doesn't work as well, and we're at a greater risk for infections like sepsis. Other common diagnoses for patients with malnutrition that are readmitted include congestive heart failure and pneumonia. So I want to talk a little bit about pneumonia. This was a really kind of interesting thing because, I mean, how many people in here have had pneumonia or know somebody who's had pneumonia? Yeah, and it's a really common reason to be hospitalized. It's kind of amazing that despite, you know, the huge medical advances and antibiotic development, community-acquired pneumonia remains one of the leading causes of hospitalization for infections in older patients and is associated with high medical costs worldwide. The prevalence is higher in older adults hospitalized with community-acquired pneumonia, and it is associated with worse outcomes, including prolonged hospital stay, higher in-hospital mortality, and increased readmission. So, as I was saying earlier, it exacerbates immune dysfunction. You know, as we age, our immune system also declines, but malnutrition makes that even worse. It impairs lymphocyte proliferation, phagocytic activity, which those are the parts of the immune system that eat up the bacteria and help create white blood cells to fight the infection, and also impairs our antibody production. It also causes muscle wasting. So this is something I hadn't thought about, but you know, our lungs are powered by our muscles, you know, the muscles of our intercostals, our diaphragm, and in order to fight pneumonia, you know, we've got to be able to clear those secretions. So if you've ever think about kind of, you know, an older adult who's not really able to cough up those secretions because of the weakness and the frailty, that's what I'm talking about here. So they did a study of pneumonia patients, and they found that the group of patients who had malnutrition, they ended up staying in the hospital an average of 1.5 days longer than patients who did not have malnutrition. And they had a 10% chance of readmitting versus patients who didn't have malnutrition, it was 4%. So it's pretty significant both at the individual level but also, you know, caregiver level, community level, and then, you know, the resources of our hospital systems. And then I think we talked a lot about wounds and pressure ulcers, but malnourished patients are twice as likely to develop pressure ulcers and 3 times as likely to have infections. And malnutrition, it just slows down the whole wound healing process. This could be a chronic wound, a pressure ulcer. It could be a diabetic wound. It could also be, you know, a surgical wound. So all of these are going to have a longer healing process, more complicated than somebody who's not malnourished. Oh, yes.
Hillary,
Yeah.
would you say half of the people you see in the hospital overnight, you know, are malnourished?
Well, you know, I do, one of the things that I see
You're
is,
sounding like this is really serious.
right, and again, we want to remember that when we talk about malnourishment, we're not just talking about somebody who's undernourished.
Right.
And you know, when we think of that, we think of somebody who's very thin, very sickly looking. Oftentimes those signs are later signs. You know, somebody could have a form of malnutrition without it being very visible. So it could be undernourished in terms of different nutrients, but also overnourished. We've talked about that as well. So I think that probably 50% is pretty right on the money. But I will say, when I look at diagnosis codes, I don't see malnutrition very often. It is very underdiagnosed. So, yeah, and I think that's just kind of brings me to the last thing I want to say is that there are a lot of screening tools that can be used in the hospital, and I think if you or your loved one is in the hospital, you know, be vocal and ask about screening for malnutrition, because there are a lot of interventions that can be done. There's you know, different types of dietary modifications. There are other types of nutrition if somebody's not able to swallow or their digestive system isn't working very well. There are oral nutritional supplements. And then I think what's really important is making sure that the appropriate education is given to the patient and their family before they discharge, and that outpatient follow-up is set up so that we can continue to stay in contact with the patient and make sure that they're following the care plan to reduce the readmission. So, yeah.
Moderately malnutrition person, how long might that take for them to rebound?
Say it one more time.
We have somebody who's taking care of at home and they've gotten malnutrition. How long would that rebound for a moderately?
I think that might just really be individual for each person and kind of the level of malnutrition and depending on what plan they might be following, you know. And, you know, somebody who is really malnourished, you know, it really is important for them to work with a dietitian and with their primary care provider, because there are things like refeeding syndrome that can be really dangerous for patients that, you know, have all of a sudden change their diet really drastically. So I think it's just really an individualized approach.
So any other questions for anybody? Yeah, go ahead.
I got 2 short ones. What is 1 gram in comparison to a teaspoon or half teaspoon, whatever?
So it
What,
kind of depends what you're talking about. A gram is a weight and a teaspoon is a volume, and so that's going to be kind of different depending if it's a liquid or a solid or something heavier or something lighter. What are you specifically asking about?
They did a lot of grams, you know, like
recipes?
sugar.
Yeah, so that's you can look those conversions up online. There's also oftentimes you can buy little cards to help with that for specific ingredients. That's going to be ingredient specific. There's kind of a push right now actually to move to using a scale in the kitchen that's in grams, so you can have that as an option. Do you have anything else to add to that?
No, I would say if you're reading a recipe in grams, I would use a conversion device. Yeah.
Well, okay. The other one, is over-the-counter magnesium beneficial or is it a waste of money?
So if you have a magnesium deficiency, it's great. Or if you have a potassium deficiency, they're really helpful. If you don't, you're probably making your pee a little bit more expensive. But that's magnesium deficiency is one of those ones that's hard because the symptoms are very generic. It's like poor sleep quality or muscle twitching, which can come from a lot of things. So if you're worried about a magnesium deficiency, have them check a lab. That's a really easy lab for us to look at. And then we can also look at your medications and make sure that you're not taking something that can lower magnesium. To answer your question.
We had one question about fresh versus frozen.
Oh, yes, yeah. Fresh is best, but frozen's not bad. Fresh and frozen are both better than canned.
Okay.
Does that answer your question? Yeah.
Better than canned.
Hi, I got here a little late and I apologize, so you might have already covered this, but the cautionary tale about supplements. Is that, maybe that's been discussed. That's okay.
No.
We don't have to get into it, but
Yeah.
I think people sometimes feel that that's a good thing, especially people that are older and watch late night TV and people tell them they need something. And believe them. So I've just seen that a lot in my practice where best is to try to have the real stuff and rather than a lot of supplements. And always best to talk to your primary care provider before you start something.
Any other questions for the panel? I'd also like to make sure everyone knows that Tyrell Arnold is here with the Area Agency on Aging. He services our area in Idaho. And his organization has brought some cards with example recipes on them. So feel free to grab a recipe card. And then in the back, Lisa has set up her diagrams of different serving sizes and things like that. So you'd be able to really get a nice visual of what a certain serving size is of each individual food. So if there's no more questions.
Tyrell will just mention the organization's resources and
Yeah, you
such.
bet.
Yeah.
Yeah, so as said, we're with Eastern Idaho Community Action Partnership. So we're the Area Agency on Aging. And, you know, we provide a lot of different resources for seniors, caregivers, those who, you know, we have people you can call in to get resources. We do partner with the Senior Center. We provide some of the funding for the excellent meals that they provide here. And we're talking all about nutrition. And we always love coming to the Senior Center because it's always excellent food. Some senior centers struggle. Not here. You guys are greatly blessed. So we also do a lot of different outreach. I have Emily here, who is our outreach worker. She also supports seniors with Medicare fraud, detection, those types of things. We have some support groups. We do have one that's a virtual group that we run, and that is for, what's the, so powerful tools for caregivers. So a lot of the groups we run out of Idaho Falls, but we do have that one as a virtual group. So if anybody is a caregiver or knows somebody that is a caregiver that could use some additional support and tools, we can offer that. So it's a great resource. We have some business cards and pamphlets here as well, so please grab one on your way out. But we just really appreciate being invited.
Thank you, Tyrell. And yes, please utilize this resource. They are friends in the industry to help us whenever we have questions here at the Senior Center. So we invite you to also get to know them because they're on the ready to give you more further reach than perhaps what we can at the Senior Center. So they are an extension of us. So I invite you to get their information and then also enjoy Lisa's displays on those food portion sizes. It's really important to get your eyes on that. It's super helpful. and she's brought quite a variety, so you can get an idea about your diets and your different meals of the day. So, yeah, thank you everyone on the panel.